Dr. Weaver, you can start.
All right. Hello, everyone. Welcome to Spine Time. My name is Dr. Joshua Weaver. I'm a neurologist and one of the co-directors of the Center for Comprehensive Spine Care at Weill Cornell. It is my pleasure to welcome you to the latest installment of our Spine Time webinar. Today, we're covering a really interesting topic. It's about muscle stimulation for the back and neck pain. I actually find this really interesting. As a neurologist, I see a lot of patients who have nerve pain, usually pinched nerves coming from the back or the neck. A lot of times we think about it in terms of sciatica type pain that shoots down the leg or the arm. When it comes to back and neck pain, though, there's actually a lot of other soft tissue that can be involved: joint and ligament and tendon and muscle. And sometimes that muscle pain can be overlooked. We do have medications that sometimes help with muscles, but there's actually a whole host of treatment options that can work on muscle and joint and some of these other soft tissues, even on nerve. We use certain stimulation, electrical stimulation, that can really help with this pain. And we have two really great experts who are here who work in our pain management and anesthesia departments, who are going to tell us more about that. So I'm excited to hear about it. So I'm just going to move on to the next slide here. Okay, so I just want to, before I jump into this, I just want to thank our speakers today, but also, on behalf of our co-directors and staff here, I just want to thank the team that really puts this all together. Roseanne and Tatiana and the rest of our neurosurgery group at Cornell that works on this. We really appreciate it. It takes a lot of work to put these webinars together. As many of you may know who have seen these before or who are patients here, we are at 59th and 2nd Ave at the Weill Cornell Medicine Center for Comprehensive Spine Care. We have well over 20 physicians on our staff, and you can kind of see here, we all sort of work together. We've got our pain management team who are going to be talking today. We have rehabilitation medicine, we have neurology, like me, neurosurgery and orthopedic surgery. We also reach out to our integrative medicine colleagues who do a lot of complementary medicine and mind-body therapies. We work with physical therapists and nutritionists and psychologists, and we really try to have a comprehensive approach to spine health. So before I introduce our speakers, I just wanted to say a couple words about the webinar, just so you all know it is being recorded. Your videos should all be automatically off, but just keep that in mind. We do have a chat function, and I actually see we already have a question in the chat, which is great. Please, if you have questions as you go through, write them down in the chat. We try to get to as many of those as we can. As the speakers are talking, I will be going through the chat, and I'll try to direct some of your questions to our speakers. Okay, so today I just want to introduce who our speakers are. We have Dr. Neel Mehta, who is an associate professor of clinical anesthesiology, also one of my colleagues and co-directors of the Center for Comprehensive Spine Care. And we have Dr. Petrou, who is an assistant attending anesthesiologist and is relatively new to Cornell. We're really excited to have him, who is an expert in this area. So he's going to tell us a lot more about it. So without further ado, I'm just going to hand this over to Dr. Mehta, and you can take it away.
Thanks, Dr. Weaver. And I'm really excited to have Dr. Petrou join us. This is his first opportunity on our Spine Time. He comes to us from Stanford, where he did his fellowship in pain management and joined us last month. And so welcome, Dr. Petrou. What I'm really excited to talk to you about today is muscle stimulation. So many of the things that Dr. Weaver talked about earlier were treatments for pain, trying to block some of the pain signals coming through a nerve and using electrical activity to try to do that. It dates back to the time of torpedo fish, where there was folks in Roman and Greek mythology that would be in pools of torpedo fish and suddenly their nerve pain would go away. We've talked about this in the past on spinal cord stimulation and other types of nerve stimulation, but this is actually a shift. And what we found was that there were many muscles that were involved in pain that were likely weak, and the weakness of the muscle led to this cascade of pain and then further weakness and so forth. And how do we treat the muscle? Well, we would send you for physical therapy, but it sort of becomes this cycle that's hard to break, because if you're in a lot of pain, how do you tolerate physical therapy? And so then you don't really get better, and we don't know what further to do. Well, there's a new therapy out that allows these muscles to potentially get strengthened by using electrical stimulation. So it's kind of like putting wires around the muscle and making them start to contract and release, doing the exercise almost like it's for you, doing it for you, doing the hard work. And in particular, that's the multifidus muscle. So this muscle happens to be one of the biggest muscles of the low back and really is involved in stabilizing your spine. So when you stand for a period of time, when you walk, this muscle is heavily involved in controlling everything in your movement. And as it gets weaker, it's often associated with back pain. And then as that starts to develop, it puts stress on the other joints, which leads to arthritis. And then it starts to cause further pain. So you get this, again, this vicious cycle. And so if we go to the next slide, this is an MRI showing the weakness and atrophy or sort of withering away of the muscle. So what we're seeing on the left-hand side is a normal back multifidus muscle that looks healthy, and there's very little white or marbling or fat in the muscle itself. And as the problem worsens, you're seeing more and more white in that middle picture, and even on the right side, very severe sort of fat developing in the muscle itself as things get weaker. And so if we go to the next slide, here's a small little wire that's placed both on the left and the right side. And it's sort of in the middle of that picture, as it looks like an X. And it essentially stimulates the muscle through power that's developed through a battery. And for 30 minutes, twice a day, the muscle starts to get strengthened. And so this is a shift from pain control to actually doing the rehabilitative work for you, restoring the strength of your multifidus muscle, which again is one of the biggest ones in our back. And so patients that had this therapy have this device in them for 6 months or a year, and they start to see strength improvement, which then leads to pain improvement, and then more functional, ability. And then the device could either be removed or maybe used less to kind of maintain the strength of the muscle. So that's, in a nutshell, what I'm really excited to talk to you about, which is the new therapy in muscle strengthening and muscle stimulation. And I think that this is going to be really a shift in how we care for back pain, because we're going to find that a lot of patients have this trouble where the muscle is weaker. So that's
that's very, very interesting. So it's to some degree not directly treating pain, it's building up the muscle strength to add stability to the spine, which then helps with pain. And is that, so TENS units I'm pretty familiar with, because I have a lot of patients who have gone to physical therapy and they'll get TENS units applied to them. Is this the same concept? It's just through this, like over the skin, as this is going directly into the muscle?
So TENS stands for transcutaneous electrical nerve stimulation. So what it means is it basically is going on the skin, and as a result, it's really working at the surface. It doesn't get down to the multifidus muscle as readily. And it's really meant for pain control, try to break up some spasm or reduce the pain. But this is completely different. This has no direct pain relief from it. This is the goal here is really kind of a way to do the exercise. And so over time, your hope is that the muscle is being worked out through the stimulator. So literally when it turns on, it causes the muscle to contract and then release, contract and then release. And that takes about 30 minutes. And then after that, it's done again in the evening. So twice a day for 30 minutes. So imagine it's kind of doing the exercises that would have been difficult for you to do. And
Right, especially if you're in a lot of pain.
Correct.
Sorry, Dr. Mehta. Yeah, look, I'm sure we'll get into this in a lot more detail too, and people already have a bunch of questions about it. I'm going to pass this over to Dr. Petrou, just to talk about a couple of other things, and then we can open this up to a broader discussion. So, Dr. Petrou, why don't you take this away?
Excellent. Thank you so much. And again, thank you for that warm welcome. I actually grew up in New York, so it's very nice to come back. So in order to extend along what Dr. Mehta was saying, again, this in terms of therapies and the focus of today's talk in terms of, therapies that are electrical in nature. So in particular, I'm interested in peripheral nerve stimulation. And you can see that directed needle tip in figure A. And that essentially, as Dr. Mehta alluded to with the torpedo fish, again, it's relying on this electrical current from the device, to send the signal to the nerves. Specifically, it's looking at stimulation of touch fiber nerves, not the pain fiber nerves. And the idea is that by activating those nerves, those touch fiber nerves, you what we call this gate control theory of that you disrupt the mechanism, you disrupt the pathway of the pain fibers. And what's interesting about peripheral nerve stimulation, which is separate from what Dr. Mehta was necessarily talking about, that functional restoration, but here it's really focused on nerve signaling, is that with peripheral nerve stimulation, the concept of there being localized or peripheral benefit, such as that can disrupt the electrical conductance of the immediate tissue, as well as alter the local blood flow of the area and the local neurochemical modulators of pain in those back muscles that are causing that axial back pain. In the picture specifically here, you can see the multifidus, as well as the other back muscles, including the longissimus. And here, the goal of the peripheral nerve stimulation is to innervate or provide signals to those nerves to disrupt the pain. And the idea is that, again, working peripherally, but then also centrally, in terms of the idea being that how we perceive pain from the cortex is disrupted by the electrical signals. I think one of the other interesting parts of the peripheral nerve stimulation is being able to do it under ultrasound guidance. And here we can actually see the muscle layers. So in that figure on the right, again, focusing on the multifidus, you can see that the star area is where the lead would go. Next to the SP is the spinous process, and the LA is the lamina. Again, the bony structures of the back. And that when you place it, you can then watch the muscle contract under the ultrasound to confirm your location. And again, to confirm your location. And I bring this up in terms of, I'm sure many of you might be familiar, for anyone who's gone to see a pain specialist, if they've ever discussed that facet arthropathy or arthritis in the spine, and oftentimes they'll offer what we call the medial branch blocks. And that's where they'll provide either numbing medicine or burning of the nerves that innervate the facet joints. And so here, again, we're looking at the medial branches, in this case, that also they're also innervating the multifidus, and that the benefit of peripheral nerve stimulation is that, yes, you are targeting the nerves that innervate the facet joint, and this would be an indication for patients who no longer respond to that ablation or that radiofrequency ablation of the medial branches. But also it's been discovered that patients with other causes of axial back pain can benefit from the stimulation of the medial branch in this format. And that being said, that was, again, and I know this is the spine center and one of the focus, but just to branch out in terms of where this field is where this field is moving, is looking at other areas. Essentially, any area, any nerve innervation, for example, of the joints, can be targeted by this peripheral nerve stimulation. Here you see, as Dr. Mehta was referring to, an implanted device. This device actually sits outside, part of it sits outside of the body, so it doesn't require that same surgical procedure. And again, you can see here with the 60 days that might tell you it is temporary. It does only last 60 days. And I do see there are some comments in the chat about who are candidates for devices such as these. And again, there's always a concern, especially if there's surgeries or previous surgeries. But this is the emphasis of that temporary nature. And that being said, what's interesting is that when they've looked at outcomes, the patients do respond not just in those 2-month period when they have the device implanted, but essentially they've been able to reprogram that central pain processing with the pain relief of the 60 days to extend further out.
That's super interesting. So really, we've got two different types of stimulations here. We have one that's kind of working out the muscles that Dr. Mehta talked about, and this one where you can sort of locally, well, you can make changes to the nerve input, it looks like, more on a local level, but also that nerve signal going to the pain receptors in the brain and kind of modulating the nerve side of things. So you've got both a nerve stimulation and a muscle stimulation that kind of can indirectly and directly work on different parts of the pain here. There's a lot of really fascinating questions that I have that are actually being echoed here in the chat. So I wanna run through this a little bit. So, I guess some people are just wondering, like, right up front, why do these muscles get weak in the first place? Are we going back to, I remember like in the 50s, those old videos where people would just get like stimulation and they would, in lieu of working out at the gym. Is this going to take over? Like, do we never have to work out anymore? Because that would be great. How do we see using this kind of stimulation?
I wish I could say that, yeah, we never had to exercise again, but unfortunately not there yet. So why do these muscles get weaker in the first place? It's often, there may be other factors that came about, that they had pain in other areas that limited their exercise. Potentially weight gain could have caused the muscles to get weaker over time. Just a busy lifestyle that changes as we get older. Mm-hmm. This therapy is not for generally our 18-year-old patients, but sort of middle to later age, where these things have sort of developed over a period of time and kind of get to a period where they can't necessarily reverse back with just physical therapy. It's not meant that this is going to be a therapy for every patient that walks in the door. Number one, it is an implanted device, so it is a minor surgical procedure to place this all under the skin. At least the first device that I talked about, as opposed to what Dr. Petrou talked about, which is actually a temporary external device that has no surgery involved. And that's the real advantage of that particular therapy. And then the other piece of it is that if you've had prior back surgery, it may make you ineligible for this because some of those muscles have been cut. And if they've been cut, it's hard to rehabilitate those. Now, if we had our other colleague on, Dr. Hartle, he often talks about one of the therapies that he does, the surgical approach that he does, is to avoid cutting that multifidus muscle because he knows how critical it is. I don't have his German accent, so I can't say it in the same way that he does it. But that's where this multifidus muscle kind of comes up again.
So, Dr. Mehta, can you walk us through like the surgical? Because it sounds like what Dr. Petrou talked about. This is a non-surgical approach, which is nice. So there are pros and cons to all these things. But for the surgical approach, where is that picture? How can you walk us through a little bit like how this works? What would a patient expect, if they showed up for this procedure?
Yeah, not to steal Dr. Petrou's thunder, but his is an injection. It's just that there's no medication coming out. It's using a needle to leave a wire behind internally. And I'll let him speak about that in a moment. But in our device, this particular rehab device, it is a very small incision into the skin, sort of in your low back area. And I don't know can you see my pointer? I guess not.
But you can tell me where it's at.
Yeah, so if you go like sort of in between L3, 4, that is where we sort of dive in under the skin, in between the bone, and it's going off to the facet joints, which are off the transverse process off to the side. So we know the nerves that activate that muscle, the multifidus muscle, are basically located right where that electrode goes and wraps around that nerve. And it turns on the device through the battery. So a small little incision is done in your soft part of your buttock area where we can tuck this battery in. And then it connects to those wires. And the wires kind of anchor in place by themselves. And then we close up this small little incision. There's no bone being cut. There's no muscle being cut. So it's really a 1 to 1.5 hour procedure under sedation anesthesia, go home the same day. So very, very straightforward, easy procedure. Certainly nothing like a spine operation or anything like that.
Got it. And Dr. Petrou, how does this procedure work, comparatively?
And I should emphasize that I think as Dr. Mehta mentioned, that it really are procedure, but best to see it as a procedure versus a surgery. I probably misspoke when I made the comparison earlier. This for peripheral nerve stimulation procedure is still done in the OR setting initially, again, to maintain the sterile environment. But then it can be done in the outpatient clinic area. But for this, for the first part, essentially, it's done under ultrasound. And as Dr. Mehta pointed out, it does feel almost like an injection. In fact, the first step before doing peripheral nerve stimulation is to do a nerve block. It's a diagnostic nerve block to make sure that it's targeting the nerve that is causing the discomfort. So similarly, it's a needle under ultrasound. In this case, where we place it's about the wire, it's about the size of a guitar string. I think something to emphasize, as Dr. Mehta alluded to, is that at the end of the day, for the previous procedure, everything it's stitched back up and it looks the same from the outside. With peripheral nerve stimulation, you do have the wire does extend out into that battery pack on the skin. So patients, it's very easy to manage, but patients will have that sort of battery pack out available to the publicly seen, versus as Dr. Mehta alluded to, everything is underneath the skin at the end.
Right. So for both of these, what does this actually feel like? I mean, do people feel electricity? Because I know we said it's electric. I mean, are they getting like mildly electrocuted here? Like, what does it feel like when they actually get this?
Yeah, so I'll talk about the muscle part. Patients describe it as sort of they feel maybe a light massage to sort of like the muscles contracting. There's nothing really like tingling or electrocution involved in this one. And again, it focuses on working the muscle. So while we're doing the procedure, we want to make sure we're capturing it. So before we close up the skin, when we place the wire, we actually, in the operating room, turned it on and look to see that the multifidus muscle contracts when the device is turned on. And so what patients will feel like, they feel sore in the first few weeks because the muscle is starting to work out. And then as it gets stronger, they feel less of that.
And what about the peripheral nerve stimulator? What does this feel like?
So they will feel some buzzing or tingling, and essentially a patient's given the remote so that they can monitor, so that they can adjust it. They can adjust the strength of that buzzing or tingling. I will point out, I think as Dr. Mehta alluded, is that previous therapy is 30 minutes twice a day versus peripheral nerve stimulation. It is 6 to 12 hours per day that the patient will be feeling that sensation.
Got it. And so I guess the next question is there good data, or even just anecdotally with your patients, does this actually work for either approach here? And are there any complications, that could happen with this kind of procedure?
Sure. Valid question. So this is a new therapy in terms of what we're providing at Cornell. So our early experience is still, we're looking into this, but the therapy is FDA approved, and it's been studied both in Europe and here in the United States through rigorous randomized control trials. And they looked at patients that either had this type of stimulator or something where, they just did conventional treatment. And the patients found that they started to have improvement in back pain in about the 6-week mark, but really that 6-month mark was when it really turned the corner. And patients had a choice at 1 year whether they wanted the device removed, of which about half did, and then the other half continued to use the device. Not all that wanted it removed was because of a negative issue. It was, the majority actually felt like they'd achieved what they wanted to achieve. In terms of complications, it's really related to the procedure. That could there be bleeding or infection? It's really far away from the spinal cord and nerve, so we're not so much worried about a nerve injury. And those first two, bleeding and infection, are extremely low. I think the biggest sort of thing to think about is that pain is often so complicated that it's rare to just have one exact problem. So while we may fix the muscle issue, maybe arthritis may still be an issue that we have to involve other therapies. And with Dr. Petrou, I know he's about to explain in a moment, but I hope you could share like all the different joints that you've been really successful treating. I mean, it's really fascinating with the different types of arthritis and different types of pain that this thing is so really accessible for.
Excellent, and I'll touch on that first. So as pointed out, patients who've had patients with history of stroke and had shoulder pain after stroke they have studied placement of this peripheral nerve stimulation device. I've noticed the patient have gotten benefit, as well as it has been for patients who have for knee pain. I think one of the interesting aspects of the peripheral nerve stimulation is being able to target any nerve. So essentially, for patients who are able to demonstrate or to show to their pain physician or to point out which part of their if there's a unilateral segment of their pain, of their joint pain, if it encompasses the whole joint, that way they can work with their clinician, the pain physician, to identify which nerve would be causing that discomfort. In terms of trial data, specifically for the joints, again, they have studied it for the shoulder joints in the stroke patients, as well as for patients with knee pain, persistent knee pain after they've had knee replacements. I want to step back, and I think I want to emphasize what Dr. Mehta was saying about, both of these devices are very safe and they're FDA approved. He correctly points out that his device has been involved in randomized controlled clinical trials, versus the peripheral nerve stimulation has not been in those similar trials. The data that they look at is for patients, all the patients had received the device. And that being said, their outcome measures, they've noticed that patients have pain relief, have decreased pain scores. They've required decreased amount of pain medications. They've been able to improve their physical activity. And I think this is important for both interventions, is that really it's a focus on the biopsychosocial approach to pain management, or that the interventions work in conjunction with the physical therapy, as well as the holistic approaches to medicine, including meditation. So I think these components all work together to optimize pain management for the patient.
I love that you brought that up, Dr. Petrou. I mean, I feel like pain is a very complicated thing that involves a lot of different structures, a lot of different types of tissue, a lot of different chemicals in the body. And by using a variety of treatment options, you're really sort of attacking the pain in a lot of different ways. And usually it's a combination of those things that really seems to help the best, especially for people who have chronic pain. I think that's really smart. And I love the fact that we have these relatively new, but scientifically backed up treatment options, that are available. We only have a few minutes. I did want to wrap up a little bit here, but there was a question about spinal cord stimulation. Which is a different kind of stimulation. I was wondering if either of you could weigh in on how that's different, and when would you decide to choose one over the other here?
Phil, if you wanted to take that one.
Sure. So, there are specific indications for spinal cord stimulation, particularly as patients who have low axial back pain with the radiculopathy. So symptoms that radiate down one leg, down the leg. I will say the peripheral nerve stimulation I showed is for the multifidus, or the medial branch, would not be the same indication. It would not help any radicular symptoms that the patient has.
Got it. So, and when you say radicular, you mean, pain shooting down the limb. So this would not be a good option for that, you're saying?
Correct. Also, I'm sure there's been just patient. The audience might know about spinal cord stimulation for peripheral, for diabetic neuropathy. And again, peripheral nerve stimulation would not be indicated, as it doesn't have a targeted nerve distribution of the pain.
And Dr. Mehta, you were working on spinal cord stimulation, right, for neuropathy pain, right? Not just even back or neck pain or spinal cord issues. Can you tell us a little bit about that?
Yeah, we just finished a study that also led to FDA approval using spinal cord stimulation for the treatment of diabetes-related neuropathy. And the reason why we chose diabetes neuropathy is just because of how prevalent it was. But it could apply to a variety of neuropathies there. So same concept, similar technologies, just different targets, different software, different companies. But yeah, this whole sort of broader range of trying to move away from medication and trying this type of electrical stimulation is really what I think is exciting in our field.
Yeah, it sounds really amazing, actually. It's complicated in the sense that there are a lot of different approaches that you can do here, through the skin, injection, with the needle, through wires, affecting spinal cord, muscle, peripheral nerve. There's just a lot of different ways to do this, and it sounds like there's a lot of really innovative things going on right now, which is great. I mean, I feel like I see a lot of people who are just, they've tried every medication known to man and nothing is really helping them. And to have more options available for treating pain is really what we really need. So I'm happy that you guys are both, working on this. So I think we'll wrap up. Any last thoughts? Anything else you wanted to say before we go?
No, I thank you for having us. And certainly, I'm glad I could share the floor with Dr. Petrou and Dr. Weaver. Always a pleasure to join you. Next time, maybe over a glass of wine.
We did our wine and spine last time, so we'll have to bring that one back. That was a fun one.
Universal one.
Excellent. All right. Well, thank you, everybody. It was a real pleasure having both of you on. I really appreciate it, and I hope everyone watching, learned something from this. And take care. Have a good rest of your week.
Thank you.
Thank you
Bye
so
now.
much for having me.